Ophthalmology, Government Medical College, Idiki. She will maybe due to some toxic abnormality of the cell, or it may be simply because of the retinal pump mechanism getting damaged. So it is seen in retinitis pigmentosa and other diseases which are mentioned here. So again, as I've told you, there is damage to the cell. It's within the cell, the space has increased, and fluid is within the cell and not outside, so it does not leak from the vessels. And therefore, it is absent on FFA, so OCT gets to be more important. And nowadays, we have a much wider view with OCT with a dense raster scanning, so we are able to get much more details of the fluid. So the disorders can be genetically linked, and the most common genetic link is the retinitis pigmentosa. So majority of this CME in retinitis pigmentosa is of course central, and there is no vascular disruption as I've said, and it affects vision, but the thickness may not be related to the vision. So the causes may be ERM or toxic products from the retina. That is, the RP is damaged. So from the degenerating RP, there may be toxic products. And the treatment of all these disorders in which there is accumulation in the intracellular space is, first line is topical or oral carbonic anhydrase inhibitors. And second drug is steroids, which can be oral or local or intravitreal. And lastly is anti-VEGF. So how do you give these steroids? Oral steroids, 500 milligrams per daily. You're tapering it slowly to 125 milligram every 3 days. And usually you need to continue this for 1.5 months at least. And similarly, topical dorzolamide, 2% TIE. For 1 year, you can give oral steroids, deflazacort, and otherwise intravitreal injections. And sometimes ranibizumab intravitreal. So as you can see here, the 6 months usage of topical dorzolamide has decreased the CME. Similarly, you can see an intravitreal injection of IVTA of dexamethasone actually has given improved CME. Again, vitrectomy, what is the use? It relieves the traction, it improves oxygenation to the patient, layers of the retina, and suppresses the release of inflammatory substances. In juvenile extinct retinoschisis, many of us have seen it, where you see a pattern like this, where you see spoke wheel pattern in the macula, and you see multiple layered inner retinal layers of cysts. Again, this is because of a genetic damage in which the retinal layers loses adhesions. So that way it starts splitting in multiple layers. And again, treatment is carbonic anhydrase inhibitors. A very similar thing is myopia. A patient with high myopia with sudden loss of vision, and you sits on the slit lamp. There is an unexplained visual loss, and this is seen in patients who have a posterior staphyloma. What you see is the split of the retina like this, a dome-shaped macula with a split like this. So this again, treatment here, steroids or drugs will not help. You have to go in for vitrectomy. 2 drugs which are important, one of them is the drug induced, of course they are bilateral, and once you stop the drug, the CME improves. But if you don't, it can cause macular degeneration. One of the common drugs is niacin or nicotinamide, which is the active agent. Niacin is a treatment for lipid disorders, and it used to be given as high doses for 1 year, 6 weeks to 1 year, and you have maculopathy, which is first diagnosed by gas. And it occurs within 1 month to 36 weeks. And the reason for this is Muller cell damage, and nuclear metabolism is disrupted here. So what you get, cystoid spaces in the inner nuclear layer, and the foveola appears bright yellow in color. So there is no leakage on FFA, and as you can see, the inner nuclear layer and later the outer plexiform layer shows cystoid spaces, and the treatment is stopping the drug. Another drug which is important is the anti-cancer drugs called the taxanes. Now they are paclitaxel, and this is for ovarian cancer and esophageal cancer, etc. And possible mechanism is RPA damage. Again, treatment is cessation of the drug which causes improvement. One problem is multiple myeloma. Now in multiple myeloma, you can get a syndrome which looks like CRVO. This is called the hyperviscosity retinopathy. Here again, it is not leaking on FFA, but you get CME. If you see the CME CME on OCT. It is quite a big CME, but on FFA it is quite silent. This is because of accumulation of immunoglobulins in the disease into the retina. Treatment is very poor treatment, that doesn't help much. And another important, of course, cause is phototoxicity. When you are operating in the operating microscope, there is a chemical and a thermal damage if you are using too much light for a long period of time, especially after intraocular lens implantation and especially after multifocal IOL. So what do you get here? On the FFA, you will see some hyperfluorescent spots. They don't leak, but you get hyperfluorescent spots. And on OCT, you get cystoid macular edema. You can try and avoid it by making an oblique light, decrease the intensity, decrease the exposure time, and after implanting the IOL, try not to use too much time. And multifocal lenses, of course, are a worse prognosis for that. So management is if you can get filters, UV and infrared filters in the IOL as well as the microscope, and reduction of surgical time. Thank you.